Okay, our next speaker is Dr. Robert Hopkins. If you've been to, yeah, there you go, Brady. Yeah, you can clap. You bet you can. Oh. What? Okay, he just changed his name. His name is Robert Hopkin. Without an S, correct. Okay, there we go. Sorry about that. I've got it written both ways, as a matter of fact. He's the an associate professor of clinical pediatrics at Cincinnati Children's Hospital Medical Center within the University of Cincinnati College of Medicine. Majority of Dr. Hopkins' time is spent caring for patients with genetic disorders, oddly enough. And he participates in clinics from fetal care to adult genetics, so the man knows the entire range of experience. He is a member of the American College of Medical Genetics Committee on Therapeutics. He knows a lot about not just 1p36, but many other genetic conditions. And his research is the application of scientific knowledge to improve the outcome for patients afflicted with genetic disorders. So I give you Dr. Robert Hopkin.
Thank you. All right. So I am really happy to be here today. I have been to a few of these before, but it always cheers me up to be able to come and spend time. And I find it really helpful to see people with some of the conditions I care for when they're outside of a medical institution, because it's a completely different experience. When they come into my office, it's all about what's wrong, what are the problems, and then I come here and I see kids running around and playing and getting into things, and it's a very different experience. So the talk that I am, whoops, what did I do? Okay. The talk that I'm giving, the work was actually, a lot of this work was actually done by other people. I don't know if any of you will remember, but a few years ago, Cassie Back came, and it was when the meeting was in Cincinnati, and we did a survey of speech and a bunch of echocardiograms on patients, or on kids with 1p36. And then the other people listed on this slide looked at those results, and now we have finally got some of the preliminary analyses done to look and see what we found out. Okay. So this beginning part is going to be stuff that's familiar to most of you. We know that 1p36 deletion is one of the more common chromosomal rearrangements. It's still one that's not very well known in spite of being one of the more common conditions. And we're trying to change that. So the deletion is really, if you do regular chromosomes, most of the time you're going to miss this, which leads some people to have a very delayed diagnosis, and especially historically made it very difficult to get to the diagnosis. It is sometimes detectable with chromosomes, easy to detect with fish, but you have to know what you're looking for. And so if you didn't recognize the condition, you weren't going to pick it up using that tool. And then finally the microarray, and now it's quite easy, and microarray is one of, and probably should be the standard first line when you think this might be a genetic condition, but I don't know what it is. It's the starting test. So historically, you had to really have a high index of suspicion. So this is what the chromosome looks like, and the part that we're talking about is anything from here up, so this white part. And this is what the chromosomes look like. These are pairs of chromosome 1. And can you tell me which side the abnormal chromosome is on? So if you look really closely from up here where I am on the stage, you can see a little puff on here, there. That one's kind of a smudge more than anything else. And then this one is more straight cut right there and right there. But you can see that that's a pretty subtle change. So if we do a real close-up on it, you can see, again, this one is just kind of blunted, and there's a puff of white right here on the top that's barely visible. And that is what we were looking for with the chromosomes, which is why this was hard to recognize in the beginning. And then these are some of the common things that have been associated with it, and what we're going to be talking about now is just heart problems. So heart problems in this have been described for a long time. So the first descriptions included some heart issues, and there are papers going with up to 70% of the kids having some kind of a heart malformation. Now, there are other papers that show much less than that, but the one that's quoted most often showed 70%. Cardiomyopathies in 20 to 30%, but nobody said what functionally that meant. And there's a pretty big range, as with everything else, but we wanted to know, okay, what, in the long term, what does this mean? And we were particularly interested in whether or not this changed with time. So the initial descriptions, if you read the early literature on 1p36, it says, yes, a lot of the kids have heart problems, and there is a cardiomyopathy, but most of the time that cardiomyopathy doesn't interfere with the child's ability to function on a daily basis and only has mild impact on heart function. But those papers were looking at infants and up to about 3 or 4 years old. And then most of the kids did not go back for any longitudinal follow-up. So we had a patient about 7 or 8 years ago that had been known to have a developmental disability, but we didn't know what it was, and nobody had really tried to do much to look into it. And for some reason, he got referred into a genetics clinic, and we did some testing, and we found a 1p36 deletion. About that same time, he started having shortness of breath, and he got referred to cardiology, and he had not been known to have any heart defect, although I don't know that anybody ever looked. But by the time he got to the cardiologist, he had very advanced heart failure, and within a year after that, he had passed away. And by then, in Cincinnati, we had about 10 patients with 1p36 deletion, and that kind of was a wake-up call because all of them were younger than this gentleman, and we wondered how many of them were going to end up like he did. So that's sort of the beginnings of this question. And then when we were doing the study that Ashley Brazil did, where we tried to find as many teenagers and adults with 1p36 as we could, we found a few, and were able to get some valuable information. And in that population, we found 4 that clearly had progressive heart disease and were ending up in late adolescence or early adulthood getting cardiac surgeries done. And we said, maybe we should do this as one of our next projects. So it was an important issue, but we really didn't know what we expected to find. So we decided that we would look at children, and it was pediatric, and we knew the kinds of people, the ages of the people who came to the meeting, so we said, okay, we're going to not have enough adults, so we aren't going to ask the questions. about the adult population because we won't have an analyzable population. So we'll say 16 and under, and they have to have 1p36 deletion, and we will, if they come to this meeting, we will offer to do an echocardiogram and an EKG and see what we can find. So we had a specific protocol designed to look at the heart with most attention being on cardiomyopathy. It was all read centrally to make it so that we didn't have to worry about technique issues or what people were calling different heart defects. And this is what we got. So we had 24 kids that we were able to get echoes on. And the average age was about 8.5. And then the rest of that stuff is numbers that are needed to calculate the z-scores that we used so that we can compare the kids to each other and compare them to norms and to other populations if we need to. So 5 of the 24 kids had previously known structural heart disease, and all of those were confirmed, and you can see up here what they are: ventricular septal defect, atrial septal defect, patent ductus arteriosus, pulmonary valve stenosis, and Ebstein's anomaly. That's a big spread. PDA is considered a very mild heart defect and sometimes doesn't even require intervention. Ebstein's anomaly is a very serious heart defect and almost always requires some kind of an intervention. And so we had a pretty good variety, which is what we expected, but only 5 of the patients came in knowing they had something. So this is more the meat of the findings. So left ventricular hypertrabeculation, which is the left ventricular non-compaction that Dr. Scott mentioned yesterday, was found in almost 42% of this study. And if you look down this list, you see 40%, and then of that 40%, the ones that had systolic dysfunction, so their heart wasn't working efficiently, is 40% of that group. Then these are some of the ways. The left ventricle not squeezing as tightly as it should was seen in 17% of the total population. Then the diastole, which is when the heart isn't squeezing, so when it's relaxed, how long was the longest dimension of the heart? About a third of the patients had that measurement abnormal. And then left ventricular volume when the heart was at rest, over 50% of the patients had that. So all of these are signs of at least a mild cardiomyopathy. So that is, we didn't have the amount of structural heart defects in this population that we would have expected, but we had a higher number than had been expected with some evidence of a cardiomyopathy, although a lot of that was on the mild end. So now, are there things about this study that can explain some of these differences from what's previously been reported? So there are. So one is the average age of these kids was 8.5. That's going to eliminate some of the most severe heart defects. They had to be people who were well enough and active enough to be able to come to this meeting, and that also eliminates some people. So we have a population that's potentially selected for not mild, but maybe moderate degree of involvement. So you're going to have some shifts in that. And we kind of expected that and had accounted for it, but we still thought that it was a surprise that we had more cardiomyopathy than had previously been reported. We do have small numbers, so a shift of 1 or 2 kids having a finding might make the percentages look off. So that also needs to be taken into account, and we clearly need to do additional studies with more kids. And finally, we were asking a question of, is there evidence for progressive heart disease? And we did this as a cross-sectional study, which is not going to be over time is their progression. So we couldn't really answer that question. Now, the findings that we had here show us just kind of a global across the board, okay, this is what we've got, these are the numbers. Hard to know what that means on an individual basis. We did have 4 patients who had substantial heart dysfunction, and we felt like required interventions. 3 of those knew prior to coming into the study, the families knew that the child had a serious heart defect, and they were in close follow-up. But we had 1 who came in, and we did the echo and said, uh-oh. And then we had to sit down with the family and explain to them that there was a significant heart problem that needed attention, and when you go home from this meeting, you need to find a cardiologist and get them involved in your child's care. That had not previously been recognized, and so that again supports the idea that there are some kids that either are being unrecognized or are having progressive involvement from the cardiomyopathy. So since then, we have gone back and looked at some of the genetics of this and tried to figure it out. And we did not, because we were not the center where the kids were primarily followed, we didn't have everybody's chromosome results or their microarray results, so we can't tell you how big any of the deletions were. And you probably can't read any of this, but right here is a list of genes that have been well studied. And this is the work like Dr. Scott does. And over here are some other genes. So he talked yesterday about SCI and PRDM1 and RARE, and there are several others. Of these genes listed here, 10 of them have published evidence that indicates that that gene has a role in either cardiac formation or cardiac function. Many of them have evidence of both of those, and nearly all of those genes also play roles in other organ systems. So while Dr. Scott was presenting some pretty specific evidence about this one, PRDM1, that gene is clearly important in causing cardiomyopathy, and if you're deleted for that gene, you are likely to have cardiomyopathy. It's not that simple, because that gene interacts directly with this gene. So if you're deleted for this gene but not that one, you're still at risk for cardiomyopathy, because the interaction that they have that regulates how the cardiac muscle contracts is still disrupted. So that one may be the key driver, and when you put changes within the single gene, that's likely to be. In any case, anywhere along, so this group here, all of these are heart-related problems. So if you look, there's tiling effect, so that the critical region for heart defects and heart problems in 1p36 is all of 1p36. And so we will find some of the more specific roles in the heart for the various genes, and you will look and notice that there's a lot less than 180 genes listed on this slide. This image was taken from a review, a recent review of 1p36 that was published just within the last few months. And it has the genes that are adequately studied that we can say something about what they do, and that means we have about 160 to go. Okay, so discussion. Heart defects are common. The cause of the heart defects in 1p36 deletion is very complex, at least 10 genes, and I suspect there will be several more. In fact, I know that there are at least 3 more that weren't listed on that previous slide that are thought to have a role, including one that has recently been published as an important cause of cardiomyopathy. The severity of the involvement really is quite variable. Left ventricular non-compaction is one of the common findings with the cardiomyopathy, and that can be either with or without a structural heart defect. So what is left ventricular non-compaction? And how does it come? So left ventricular non-compaction can be a benign finding in some patients. Actually, the cardiologist that helped us with this study, if you do an echo on him, you see hypertrabeculation, and I guess that's one of the reasons he's so interested in it, but he has no health problems. On the other hand, left ventricular non-compaction is also associated with heart rhythm disturbances and with increased risk for blood clot formation. In neonates, it has a high association with heart failure and mortality. And in adults, it's also got a high association with life-threatening complications and some early mortality. In childhood, so the age range for the kids that we had in this study, it usually is not associated with overt major problems. There is a benign form, and in the benign form, if you do the echocardiogram, you do see the hypertrabeculation, but you have normal wall thickness on the heart, so the muscle thickness is normal, normal diastolic function, and normal squeeze function from the heart. But these are all of the other types of left ventricular non-compaction. So it can be associated with arrhythmias, with a heart that's stretched out too big, with a heart that has too thick of muscle, too thick of a wall, with a mixture with the atrium dilated and the ventricles thicker than normal, and with restrictive, and with heart malformations. And each of those categories has different risk factors and predicts different outcomes. And each of those categories can be seen with 1p36 deletion. So I don't know if you can see this. Probably not. So the arrow here points to some lines in gray that can be seen on the computer screen, but probably not on this screen. And then so this one is the benign form, and the others show some of the details of the other. And one of the things that I put that up for is that I look at them and they all look like hearts. And that's about all I can say unless I look at the description below and say, oh, okay, I can see that. You need an expert if you are doing this. So next question is, so what do we do? So we looked at the literature, and we found, in this study, we found one unrecognized case of severe cardiac dysfunction. Ashley Brazil's study, we had 4. There are at least 2 cases of clear progression of cardiomyopathy in adulthood in individuals with 1p36 that are published as single case reports. And we don't know how frequent that is. So that led us to say, well, what do we now recommend? Because we knew we wanted to come here and present this. we also want to write this up as a paper and say to the doctors that might be caring for your children, this is what we think you should look at. So what do we do with this information? So recommendations that we came up with: all individuals, whether they are children, adolescents, or adults at diagnosis who have a 1p36 deletion should have a good heart evaluation. And if you have a family member who has that diagnosis and they haven't had a heart evaluation, you should request one. Treatment, if they find something on the, so if they do an evaluation, do an echocardiogram and an ECG, and they find evidence of heart dysfunction, the treatment for that or the monitoring for that really depends on which of the categories of cardiomyopathy are present. So it can be quite different. We do think that a periodic, and I talked to Dr. Scott about this and he agreed with it in principle, although we don't know how long the time should be, but we recommend that at least some periodic reevaluation should be done. So at our center, we're going with every 2 to 3 years for the people who have good heart function at the time of their initial evaluation. I would not be surprised if that doesn't spread out to every 5 years at some point when we gain some confidence in being able to say, for now, everything looks good and this is predicted to be a stable finding. So, I've given you some information. I recognize that there are some gaps in this information, and now I want to open up for questions and see if anybody has anything or comments. Yes?
So my daughter got echoes every 3 years for a long time because she started out with median that's since been foiled and is healthy. Now, this last January, she had an echo, and her ejection fraction was a little bit lower than it had been previously. And so they repeated 4 months later, and we just had it again in May, and it's lower than it should be, but only mildly lower. But the heart muscle looks good, so the ejection fraction really is the only thing that's indicating potentially a problem. You mentioned that what you do depends upon what thing seems to be showing evidence of a problem. What does EF tell you in absence of anything else?
Right. So ejection fraction is when your heart squeezes, how much of the blood that's in the heart actually leaves the heart and goes forward in the direction that we want it to, and that number is typically about 60%. And if it's significantly lower than that or significantly higher than that, that indicates that there's a problem with the way the heart is functioning. Now, what does that mean? If it's just slightly below that, you probably wouldn't notice any symptoms in the individual, but you do want to keep an eye on that and make sure that it's not getting worse. If it is getting worse, there are medications that can be used. Sometimes there are also implantable devices that can help, especially if the heart rate or the heart rhythm are not adequately controlled. That is precisely, looking for that and catching it at an early phase is precisely what we are recommending the routine follow-up for. As far as what to do with your child and an isolated mild decrease in ejection fraction, I am not a cardiologist, and I'm going to defer that to your cardiologist.
All right. There we are.
Yeah, I have a question. My daughter had an ASD. It was closed. And now the heart's functioning perfectly, and everything's fine. Is there a possibility something could go wrong in the future?
So that's one of the questions that we have, and the answer right now is that it appears that a small percentage of individuals will have unrecognized or no recognized heart disease and will develop it later. We don't know how common that is, and unfortunately, we don't have the ability to go back and pull records on any of those people because they didn't have any baseline studies, so we can't go back and say, well, did we miss something subtle on the first echo that could reassure us so that when we get a really normal echo, we can say, we don't need to worry about you. So for right now, I would say your daughter is probably at low risk, but I would still recommend checking every 2 to 3 years.
They do it every year. They used to do it every 3-4 months. Now they do it every yearly, and so far everything's fine. But my question is in the future,
Yeah, and so I would say I would keep doing it. But if she gets to the point that the cardiologists say, "Wow, this has been stable for a long time," there has been a tendency in the past to just discharge the kids from any further cardiac follow-up. And what we're saying is maybe we shouldn't do that, or at least if we do decide, wow, we are not going to do any more echoes, because echoes are kind of a big deal. They're very expensive, they're time-consuming, and if you have sensory issues, that cold gel alone is enough to set you off. So we don't want to do any more echoes than we need to, but we should at least give families, if these things happen, let us know, because we need to go back and reevaluate the heart.
Thank you.
Okay, other questions? Julie.
Hi.
I have a question, and I'll make it quick. She was a tetralogy of Fallot repair, and 8 years ago we had a new pulmonary valve, okay, and endocarditis, okay. Last year, July 1st, they threw us into congestive heart failure. Went in and did a TEE, threw me in congestive heart failure, said there was absolutely nothing we could do. Sent us home, put us on Lasix, put us in hospice for 7 months. Found out March that they didn't know they put us in hospice, and went in and had another TEE. This time they saw the heart, her valve, there's a clot in there now, and we're trying to move forward. And I would like to know, and the only way they can see anything on her is with a TEE, because the echo, she's too wide, thick, and all that. And first of all, have you ever heard anything about that? One time they did the fraction, that hers was 32. And then when and in the midst of this, being in hospice, and it's all going through the same hospital, we had a BMP about every month. There was 2 that were very high, and then they were all in the normal too. Called up and said, hey, what's our restrictions? I said, you don't have any restrictions. Like, she's been put on hospice. We dumped all of her medicines, we dumped everything. Now we're restarting again. And have you ever seen a heart? I'm sorry, they screwed up, but, and they say, but I'm like, how can you went from one thing, we couldn't see anything, even said, hey, how about a heart transplant? Absolutely nothing. Went in and dumped off 15 pounds of fluid and made it through pneumonia 3 times this year, and it was like, and now we found out, and so they said, I'll come back in a year. And I'm like.
So there's a big challenge in measuring cardiac function, and especially if you have difficult windows. So if they're using echo and you have a very large patient or thick bones or a lot of fat tissue, that makes it harder to get good images. There are additional technologies that can be used that would get you better pictures, including, I think, the The most advanced technology that's being used now, and that gives actually beautiful pictures of the heart, is cardiac MRI. And that's a really good tool for looking at a number of things to do with heart function. It will pick up any scar tissue in the heart better than an echo. It will pick up things like blood clots in the heart very effectively. It will pick up fluid around the heart very effectively. So there are other things that can be done to look at her heart function. You need to get with a cardiologist who has some expertise in cardiomyopathies and have that person work with other people who have experience with tetralogy of Fallot, so structural heart defects, or if you're really lucky, you can find somebody who has both, but there's not a lot of those guys around. Yeah, and as far as moving people in and out of hospice, that should be easy, because we can't predict those kinds of events very well. So in the ideal setting, you would be able to have somebody go into degrees of limited care and then back, in addition to just comfort care only. In some places, hospice only does comfort care only. I don't think that that's an appropriate mechanism, especially when you're talking about young patients. You should be able to transition seamlessly into levels of care depending on the acute need, and always treat anything that's causing immediate discomfort.
Hi, Molly had a lot of cardiac issues at birth, and she had surgery and some things resolved. And then we were seen every year, and then it was every 2 years, and then eventually by 12 years old, they discharged her. Like you said, it was common. By 16, she needed dental surgery, and they wanted cardiac clearance. And I was annoyed, but I thought, okay, we'll go in and do it. And then was shocked to find out her ejection fraction was only 24. And she had pretty much no symptoms other than like being winded. And she was put on medication, and now it's about 42. But my question is there any long-term effects to taking the medications to improve ejection fraction? And is she going to have to adjust the meds as she gets older? I know they adjust it if she gains weight or loses weight, but how will age affect and long-term use of these medications?
So the age, I'm not sure how that would affect it. The times that they adjust it, obviously for any weight gain, weight loss, they adjust the medication. They also adjust the medication based on the response. So if you give the medication up to the dose that you need to get an adequate response, or to when you get to a dose that you think is the maximum safe dose. And if you get to the maximum safe dose and you haven't achieved the goal that you have for that patient's heart function, then you look for other options, other medications, or other things that you can do that will help to improve the patient's heart function. As far as is that safe in the long term, actually there's a lot of adults, not with 1p36, but there are a lot of adults that go on long-term heart medications. And I remember I had a landlord who was on medications, and she could barely walk across the apartment floor. And this is when I was in medical school, I was just sure that she was going to come and check on me someday and just collapse. And 20 years later, she was still doing the same thing. So you can be on these medications for a fairly long period of time. Some of the medications have a very narrow dosing window, so you really want to talk to your doctor about making sure that you're dosing it correctly. Some of the medicines, if you eat the wrong foods, if you change the amount of exercise you have, any kind of a health issue changes the amount that's in your bloodstream. And that also is something that you want to pay attention to.
So if she's not having cardiac symptoms, should I not really be that concerned about a low ejection fraction? Is it just how her body works? You know?
So a low ejection fraction, if you down in the 20s is pretty low. I would expect her to have some exercise intolerance. Now, whether she's trying to do enough exercise that becomes symptomatic, I don't know, but her cardiac reserve is going to be very limited. With that, the other thing that's really important and that you want to maintain her heart function for is as the ejection fraction decreases, the risk that you will have heart rhythm problems that can lead to cardiac arrest or to things like ventricular tachycardia that can be life-threatening in an immediate sense, not in a chronic sense, goes up. So you want to keep it into a window where the heart is functioning well and the rhythm is consistent. So you would work with your cardiologist to answer that.